Hello and welcome to Ultrasound Case of the Month. My name is Tristan Withers and we're going to be going through a case today where we used ultrasound, and I'm going to talk you through what the pictures mean, how to interpret them, and how it changed the management of the patient in today's case. This is our first case and let's get straight into it. So we have a 68-year-old female. She presents to the emergency department with a 2 to 3 month history of dyspnea and decreased exercise tolerance. She's been producing small amounts of yellow phlegm, but she hasn't had any fevers, weight loss, or night sweats, and she's seen her GP a week ago who started her on doxycycline. She's been taking this as prescribed. She's got a past history of hypothyroidism, and she's also had some neuropathic pains in her feet, but she doesn't have any significant cardiac or respiratory diagnoses. She lives alone, but she has a very nice son who lives 2 hours away, and she has supportive neighbours that live next door. She's a heavy ex-smoker with a 40-pack year history, only recently having given up. She only rarely drinks alcohol and does not take any recreational drugs. On examination, she's tachypneic to a rate of 28. She has oxygen sats of 85% on room air, and these come up to 96% on 4 litres of oxygen. She's got reduced air entry at the right base with dullness percussion in the same area. She's got dry mucous membranes, but otherwise an okay heart rate and blood pressure. She's got a mildly distended but non-tender abdomen. She's got no neurological deficit, has normal blood sugar, and is afebrile. She's got a normal venous blood gas with normal CO2, pH, and bicarb. She's got a lactate of 1.3. Her bloods show normal inflammatory markers. They also show that she's hyponatremic with a sodium of 126. And she does have a low serum osmolality, but her urine osmolality is normal, so she doesn't fit the criteria for SIADH. Otherwise, she's got normal renal function, and her liver function is also normal. She had this chest x-ray, which was reported as showing a moderate pleural effusion with consolidation, and you can see the large area of opacification at the right base. She was started on antibiotics, and these were ceftriaxone and azithromycin, which is our local guidelines for a severe community-acquired pneumonia. She was referred to the respiratory team for admission. They asked us to add on metronidazole, and they also asked us to cite a chest drain in the ED. So we performed an ultrasound with a view to citing this drain, and I'm going to talk you through the images that we got. So this is a view on the left, and the first thing to say about lung ultrasound is that the machine does not try and remove any of the artifacts. Mostly on other presets, if you're looking at the abdomen, for example, the machine will do its best to remove all artifacts from the picture, but on lung ultrasound, it will leave them in. The probe is in longitudinal, which means that the left of the image is towards the head of the patient, and the right of the image is towards the feet of the patient. We can see a shadow from one of the ribs here, and we can see a bright white line, which is the pleura. The probe would be up at the top of the picture, then we'd have the subcutaneous tissues, then we'd have the two layers of pleura that slide along each other if there is no pneumothorax. And then here in the aerated lung, we see this fuzzy appearance, which is a scatter artifact of normal aerated lung. We can also see these bright white horizontal lines that are reverberations of the pleura. So they're just an artifact from this pleura up here, and they're another feature of normal lung. I'll play the loop so you can see what it looks like when she breathes. You can just about make out the two pleura sliding along each other, although you'd need to decrease the depth to see that clearly. Otherwise, this is a pretty normal looking image of lung. At the left base, and now we've taken all the artifacts out again so that we've got a clear view of the soft tissue stuff down here. Again, the head of the patient is towards the left of the image, and the feet of the patient is towards the right of the image. We have a rib shadow going through the middle of the picture here, and we can see on the left towards the patient's head there is some normal aerated lung. Then there is a bright white line that you can only see the bottom of here, which is the diaphragm. Beneath the diaphragm on the left we have the spleen, and beneath the spleen we have the left kidney. You can sometimes see some bright white dots here that represent the transverse processes of the spine, and the important thing if you see these is that they should stop at the diaphragm, so they shouldn't continue all the way up to the left of the image. And the reason for that is the aerated lung in between the probe and the bone will obscure everything behind the lung, so you won't see the bones clearly up here. If you do see them, that can be a sign of something abnormal, and we'll come on to talk about that more later. Looking at the right lung, so we're now looking at the right anterior lung with the probe still in longitudinal, so the head of the patient is on the left of the image and the feet of the patient is on the right of the image. We can see there's two rib shadows coming through this picture. We can see the bright white line of the pleura at the top. We can see some A lines. And if I play the loop, you'll see some B lines, which are some torch-like beams that go all the way down to the bottom of the picture. And these can be a sign of interstitial fluid, like from pulmonary edema, or it can also be a sign of another interstitial syndrome like fibrosis. If I play the image, you'll see those B lines shining all the way down to the bottom of the screen. You can see some A lines moving around as well, although they get obscured by the B lines when they appear. You'll see the pleura sliding up at the top here, and another thing you might notice is a small black patch just beneath the pleura that's moving around with it as the patient takes breaths in and out. We'll take another look at that in more detail on the next slide. So here we can see a zoomed in picture again. So we've got the ribs on either side, and then we've got the pleura, and then beneath the pleura we can see this dark shape that almost looks like a bite has been taken out of the lung just beneath the pleura. So there's a kind of pleural irregularity here. This is called a shred sign and is a sign of some subpleural consolidation. If you look down towards the feet end of the patient, you can see something else that looks a bit irregular down here. And we'll take a look at this bit of lung on the next image. So this is the right anterior lung but lower down. Again, we can see we've got normal lung, which is looking all fuzzy up at the top of the picture, so on the left-hand side towards the head. We've got the two ribs here. And then all of this lung down here looks quite abnormal. So this is a slightly strange looking area of lung. It doesn't look like normal aerated lung, and it looks a lot denser than the fuzzy appearance that aerated lung gives. So this looks almost more like soft tissue density stuff, and it's got the appearance of an area of consolidation. Another thing you might notice is another black area up here coming from the pleura, and that's another shred sign, so a suggestion of subpleural consolidation. If I play this loop, you'll see actually there's quite a large area of lung which looks really abnormal and consolidated and has some patterns in it that might be bronchograms, and it definitely doesn't look normal at all. Now this is an image of the right lung base. So this is an interesting picture because we've got some of the features that we had on the left. So for example, the bright white line coming through the middle is the diaphragm. Beneath the diaphragm on the right, we have the liver instead of the spleen. And around the liver, there's a capsule, and that capsule shows up as another bright white line here. We have some transverse processes of the spine at the bottom of the image, and these continue up above the diaphragm, which is an abnormal finding. And the reason that we can see these bones so clearly on this view is that above the diaphragm, we have this area of fluid density material, which is this large black area. And then above the black area of a likely effusion, we have this area of lung. And this lung looks quite abnormal. It doesn't look like that fuzzy appearance that normal aerated lung has. It looks again almost like a soft tissue organ. What I'd like you to do now is look at the lung up here and then look at the liver down below the diaphragm and notice that they actually look quite similar, both in texture and the pattern of the material and also the density in terms of how bright or grey the ultrasound image is. So this looks very similar to the liver, and we call this hepatization of the lung, and this is a sign of consolidation. I'm going to play the loop now, and I want you to notice a few different things as I play it. So the first thing to notice is that this bit of lung is flapping away in the effusion as the patient breathes, and you can see the other corner of the lung doing the same thing. The second thing to notice is that there are these kind of sparkly things in the black area of effusion. So this is a suggestion that there's some echogenic material in the effusion, and this might be pus or it could be blood, so we could be dealing with an empyema or hemothorax or something else that's complicating the effusion and making it not just simple pleural fluid. The final thing to notice, if you remember we were doing this to potentially cite a drain, is, and just to give you an estimate, I'll get you to look at the depth gauge on the right of the image and then compare it to the size of the effusion. So the width here just above the diaphragm is probably only 3 centimeters or so. And up at the top of the image, it's probably about 2 or 3 centimeters as well. So it would be quite a risky chest drain to put in blind because you don't have a lot of space to put your needle without hitting one of the organs. You could do this under ultrasound guidance because you've got enough space here to put a needle through under ultrasound vision. But again, you might feel that this would be a more appropriate drain to be done in the interventional radiology suite by a radiologist. It depends somewhat on where you work and what kind of support in terms of staff you have to help you. So we made a diagnosis of a large area of consolidation with collapse and hepatization of the right lung. We said that there was a small to moderate effusion that we didn't think was suitable for drainage in RED, and we called the respiratory team to inform them of the results. They arranged a CT chest. Unfortunately for this patient, the CT chest showed a large right-sided hilar mass with mediastinal invasion, marked lymphadenopathy, and a post-obstructive consolidation with an effusion and likely lymphangitis carcinomatosis. They said that a lung primary cancer was most likely and that small cell lung cancer could have this appearance. So that's the end of the case. I hope you've enjoyed it. I hope you had a good time reading and watching and looking at the videos of the ultrasound scans. And I hope that if you found some of these same findings in one of your own scans, you'd be able to apply them and interpret them in the same way that we've done today. Thank you.